Thanks, guys, everyone, for joining us today. Have an elite group of advanced prostate cancer providers. Really a pleasure and honor to talk to you about some of the most recent innovations in metastatic castrate-resistant prostate cancer, as well as metastatic castrate-sensitive prostate cancer. I'm going to start off with you, Ken, Dr. Kernen. How do you define mCRPC versus mCSPC to your patients? What do you tell your patients?
Sure. I think, unfortunately, I think we all know we're seeing kind of an epidemic of mCSPC patients, right? People aren't getting screened enough. They're coming in with these high volume, high PSAs. So we try to tell them, you know, prostate cancer runs on testosterone, so to speak. And if we give you some medications that lower your testosterone, that basically makes you hormonal sensitive, and that's going to stop that prostate cancer growth, as opposed to once you've been on that medicine for a while, the body the cancer cells become immune to that hormonal therapy. So your testosterone is still really low, but that cancer has started to escape that pathway and is now growing again. So that's kind of how we explain metastatic castrate-resistant prostate cancer. And obviously the metastasis means that cancer spread for the patient.
And clinically, when you're seeing patients, do you order a testosterone? Do you frequently check a testosterone?
Yeah.
What's your laboratory protocol for evaluating these advanced patients?
Yeah, so that's a great question. So since I did my fellowship at Baylor a million years ago, that was kind of beat into my head that anybody who had prostate cancer got a PSA and a testosterone. So I've just always done it. I know some people don't do it, but it's, you know, you never know when someone really isn't castrate resistant. Maybe they just didn't get the shot that month, or maybe the shot didn't work, or, you know, we had a crazy case where someone was born with only one testicle and got an orchiectomy, and then still you check their T levels and we found out he had a nubbin on the other side. So unless you test that testosterone, I don't think you really know what's going on. So honestly, every one of my prostate cancer patients I've ever treated for anything, even guys on active surveillance, I've gotten a testosterone.
Yeah, I think that's critical because these drugs were approved to lower testosterone.
Right.
They weren't approved to lower PSA.
Right.
And I think it's a common mistake for urologists to
Yeah.
follow that PSA. Dr. Frontera, when you look at the testosterone levels that you're getting on your patients, is there any target that you look for? We hear negative 50 or less than 50 or less than 20. How do you look at that testosterone when you're evaluating patients with advanced prostate cancer?
Yeah, that's a very good point. Historically, it was 50 was the cutoff, you know, and that's what many of the trials were made and guidelines. But I think it's recognized by most that 20 is a better level, a better marker of response to treatment. So I usually use 20. Is what I usually do. And if they are higher than that, then like Ken said, there are several possible situations. Then it's good practice to check gonadotropins to make sure that they are responding to the drugs if the testosterone are not as low as you would expect. Of course, exogenous testosterone has to be considered as pretty rare in that group. But no, 20 is what I usually go by.
No, that's good feedback, and I think, again, testosterone is really critical when managing these patients. Otherwise, you don't have a really good assessment, are they castrate sensitive or castrate resistant. Some of the things that we've seen recently is the integration of new imaging modalities, specific PSMA PET scans. PSMA PET scans have been approved for about 2 years. Dr. Palka, how have you integrated PSMA imaging into your practice?
So it's an interesting new technology that has, you know, changed the landscape of prostate cancer, both treatment and diagnosis. Initially, it was quite challenging to get it approved, but now as it's become more integrated into each of these diagnostics and therapeutics, it's much easier to get for my patients. And so not only with patients who have possibly recurred after localized treatment, but also patients who have come in with metastatic, de novo metastatic disease or high-risk disease, it's been an invaluable tool to assess the patient and give them a real good idea of where they stand in terms of their actual overall disease state, and then also future modalities of possible treatment.
Yeah, I agree. It's been disruptive technology. One of the, you know, Dr. Palka talked about is initial staging and an advanced disease. Once a patient has established advanced disease, how do you integrate PET imaging? What's your, you know, your protocol when using it? When would you've staged the patient, you started them on therapy, then how do you look at PET, or how would you utilize PET in those patients?
Yeah, that's also a very good question. Typically, we like to image the patient every 6 months, even if they're responding to therapy, because we know there are cases when they could be progressing without the PSA being a good marker of it. Now, the question of the PET scan is expensive, and sometimes we have a good pushback from the insurance companies. It is the best imaging, but we cannot always get it. So I think that if you suspect there's progression, you can document, the PSA is going up, there's adequate testosterone levels, et cetera. It's usually easy to get a PET scan. If not, you can go back to the traditional bone scan and CT scans. And I usually go, we should the CT scan. If I have a patient who has primarily metastatic lymph node disease only, then I go first for the CT scan, at 6 months, say, for example. If it's, on the other hand, is bone predominantly, then for a bone scan. I get probably a better image, the idea what's going to happen. But if those two images modalities don't really reflect or I'm concerned about it, then I push for a PET scan. It is the standard of care, it's the gold standard.
So Rene talked about surveillance imaging even in a non-progressive PSA situation or low PSA. Can you do that too? What's your strategy or your protocol for imaging? Is it always PET, or are you tailoring involving conventional CT bone? What's the thought process
Yeah,
there?
so especially in mCSPC patients, so in those mCSPC patients, you see them, they've got a PSA of 500 or 1,000, widespread disease, I'll always go to PET for that. And then I probably differ a little from Rene in which I'm probably not going to really scan much anything later in 6 months. I'm going to wait for a year, and then I'll get that PSMA PET at a year for a number of reasons. One is it's great to see almost all that disease disappear, which helps us and makes us feel better. Most importantly, helps the patient feel better. And then we consider doing some localized therapy at that point, maybe with radiation therapy or targeted therapy for those metastases that are there, especially for bone metastasis. And then, again, I agree with Rene. We've all seen those patients who you think, oh, their PSA is great, or they've been followed by somebody else, they come see us, and they really have had progression, but that PSA is still really low. So at a minimum, I'll try to get a PET scan now once a year and fight for that, just because I think it's the best imaging, and I think we're clearly going to miss some stuff with CTs and bone scans. So then, really, what's the point? We're just missing something probably.